Thank you, Mr. Chairman, members of the committee. My name is Terry Batliner. I am a dentist and an M.B.A. I'm an owner of a dental practice called Sage Dental Care outside of Boulder, Colorado. And I'm the Associate Director for the Center for Native Oral Health Research at the University of Colorado. I'm also a member of the Cherokee Nation of Oklahoma. I've been involved with Native American health issues my entire career. And first, I just want to, again, talk about Title 10 of ACA. It has language in there that prohibits the expenditure of federal dollars to support dental therapists outside of Alaska, even in Native communities, unless the state in which those tribal entities reside has a law that makes the dental therapy legal. Now that's, I think many of us would find that an affront to tribal sovereignty and believe that this language is a definite problem. So I wanted to talk a bit about the issues of oral health in Native communities. First of all, if you look at the US generally, about 21% of the children ages 5 to 19 have untreated decay. But if you look at the information for Native American groups, Kathy Phipps, a researcher, has reported some information recently by IHS administrative areas and showed that the Navajo area had children ages 2 to 5, 66% of them had untreated decay. The Albuquerque area, 57% of children ages 2 to 5 had untreated decay. And Alaska is 47% of the kids had untreated decay. Now, I've done some work in New Mexico in tribal communities. And if you look at Santo Domingo Pueblo, you find that the percentage of kids with untreated decay is about the same as the average for the Indian Health Service nationally, around 50%. But if you look at the adults, the fact of the matter is, and kind of the untold story in Native communities, is that the oral health of adults is even worse than children. They have more untreated decay, they have more difficulty accessing care. And the same is also true for large Indian nations, multi-state Indian nations have 70% of the kids have untreated decay. Now these are some of the highest rates of untreated decay in a disease called early childhood caries in the world. The only other place we know that with rates this high are Aboriginal communities in Australia. And what I'm talking about are kids at the age of 3 that have nearly every tooth in their mouth decayed and have to go to the operating room to be treated. They're in pain, they have pus coming out of their teeth. It's a disaster. Now, there's some approaches that have been proposed to try and make this better. Some of those deal with prevention. And we're all for prevention, but many studies have shown that knowledge does not directly translate to behavior because life intervenes, social pressures, everything intervenes. So the idea that you can prevent things without treatment is an artificial discussion. The only way you can make things better in these Native communities or inner city communities or rural areas is to have treatment plus prevention. You have to be able to fill the holes, and then you have to work to prevent new holes from forming. And that's the only thing that will work. Now, we hear that dental decay is preventable. If we just start with this new group of folks, new kids coming up, we can prevent disease and they'll be great for the rest of their life. The Indian Health Service has spent the last 40 years prioritizing care for kids. It does not work. They have shown conclusively that it does not help people to be healthy when they're adults. So what we really need is prevention, we need treatment, and we need it for both children and adults. So, you know, we all know that certain things are preventable. I know if I ate better, I'd weigh 170 pounds, and maybe my risk for heart disease would go down. But, you know, our behaviors aren't always tied in with our knowledge. So I ask your help in helping the tribal communities implement what really is a native solution to a native problem. I mean, dental therapy came to this country through the Alaska Native Tribal Health Consortium. And they looked around at the problems they had and proposed a solution that worked for them. That solution is desired by Native groups down here. And, but it can't be done due to Title 10 of ACA right now without the state passing a law that makes dental therapy legal. Now, some discussion about cost effectiveness, I can't live without talking about that. Dental therapists are definitely cost effective. If you look at my practice, I hire dentists, I usually pay them 30% of production, and an average production is $300 an hour, so I pay them $90 an hour. We pay dental hygienists about $35 to $40 an hour, and it would be reasonable to think that a dental therapist would make somewhat more than a dental hygienist because they can bring in more revenue, so $45 an hour. That's still half of what we pay a dentist. Now, when you look at communities of need, rural communities, Native communities, dental therapists can do most of what's required to help people in those communities. So they can do it more effectively, more cost effectively than dentists can. And then how much is a training program? You have a hygiene program here in Las Cruces. With some modifications, it could provide training to dental therapists. And it could probably do it very cost effectively for just some slight increase in faculty, because they already have a dental hygiene program plus a dental assistant program. So they have all the equipment and instruments required to do that. So that's my remarks, and I appreciate the opportunity. Thank you.